Bismillah ar-Rahman ar-Rahim. We will start with quote of the day. Moses said, "No, indeed, with me is my Lord. He will guide me." Today's topic is human resource management. I am Dr. Taimia Ayub, and I am presenting this topic under the supervision of Professor Dr. Sahira Afzal, Dean Institute of Public Health, Lahore. So, this is the outline of today's lecture. We will start with the introduction to human resource management, then the planning part, recruitment and selection, training development, performance, compensation and retention, and how it is relevant in Pakistan's context. In the end, we will be doing multiple choice questions. So, let's start with the introduction. What is human resource management and why does it matter? Human resource management is the strategic approach to the effective and efficient management of people in an organization so that they help the organization gain a competitive advantage. It sits at the intersection of people, processes, and performance. So there are some traditional personal management, and now there is modern human resource management. So for the traditional personal management, the focus was on administrative tasks, whereas current focus is on strategic partnership. Employee was viewed as a cost to minimize in the traditional method, and in the modern techniques, it is considered as an asset which should be developed. And the approach previously was reactive, but now it is proactive. Role of manager was more of a directive role in the past, whereas now it is for facilitative role. And the time horizon for the traditional personal management was a short term time management. But now, with the modern human resource management, it is considered to be a long term thing to be done. So, why human resource management is critical in the health sector? For patient outcomes, skilled, motivated health workers directly improve quality of care and patient safety. Largest cost driver, 70 to 80% of health system budgets are spent on human resources globally. System resilience, adequate, well managed workforce is key to pandemic and disaster preparedness. Equity in access, strategic HR deployment reduces urban rural disparities in health service delivery. Currently, there is a severe global health workforce crisis. About 18 million projected health worker shortfall is to be expected by 2030. In low and middle income countries, bear 90% of the disease burden, but have only 45% or even less than that of world's health workers. Pakistan has one physician and zero point 0.6 nurses per 100,000 population, well below the WHO threshold of 4.45. High attrition rates, migration, and poor retention worsen existing shortages in rural areas. Effective human resource management can reduce turnover by up to 30% and improve workforce productivity significantly. So now we come to this next section, which is the HRM planning, which depends on forecasting and planning for the right health workforce. So this is the planning process specifically for human resource management in health sector. It starts with the environmental scanning, analysis of internal and external factors affecting workforce, then demand forecast, estimating future health for workforce requirement, then supply analysis, assess current and projected workforce availability, then gap analysis, identify surpluses, deficiencies, and skill mismatches, and finally, action plan, which depends upon recruitment, training, redeployment strategies. Workforce need assessment methods. These include health needs based estimate workforce required to address population health needs, starts from disease burden and service delivery targets, best for universal health coverage planning. Then we have service target based calculates staff needed to deliver a defined package of services within given facilities and workload norms, best for facility level HR planning. Then we have population ratio, uses staff to population ratio, for example, WHO benchmarks, simple but doesn't account for epidemiological context, best for quick national estimates. And finally, we have workforce utilization, current staff deployment, absenteeism, and skill mix to optimize existing resources, which is best for efficiency focused reforms. Human resource planning tool in Pakistan's health system. Key national frameworks and data systems used for health workforce planning are Health Workforce Registry, maintained by Pakistan Medical Commission, or now known as Pakistan Medical and Dental Council, and nursing councils to track registered health professionals. District Health Information System captures facility level HR data, post vacancies, absenteeism used for planning at provincial level. National Health Accounts track spending on health workforce to inform budget allocation and policy decisions. Health sector strategic plans, provincial plans that include HR targets aligned with SDG 3 and UHC commitments. Community Health Workers Program, Lady Health Visitors Program with dedicated HR planning mechanism. So these are some of the national frameworks and programs and data system which are used particularly in Pakistan. Now we come to the next section, which is the recruitment and selection, meaning attracting, selecting, and onboarding the right health professionals. Recruitment strategies in health sector include internal recruitment and external recruitment. Internal recruitment consists of promotions and transfers within the organization, rehiring retired health professionals, succession planning for leadership roles, internal job postings via notice boards or intranets, lateral moves to fill critical gaps. Then we have external recruitment, which includes Public Service Commission, Federal Public Service Commission, or provincial public service commissions, medical universities and nursing school recruitment drives, health job portals and social media campaigns, rural incentive based targeted recruitment, international diaspora engagement programs. Now we come to the selection processes and what best practices are there for the selection process. First is the job analysis, define role, competencies, and essential qualification before advertising. Then we have application screening, shortlist based on merit criteria, use structured scoring rubrics. Then we have written or MCQs test, but it is not always essential. Assess technical knowledge, standardized and validated instruments. Then we have structured interviews, behavioral and situational questions, panel interview reduces bias. Then we have reference check, verify credentials, past performance, and professional conduct. And finally, we have offer and onboarding, conditional offer, medical clearance, structured orientation program. Recruitment challenges in Pakistan's public health sectors. Key barrier identified by public health manager and postgraduate researchers include bureaucratic delays. Vacancies take 12 to 24 months to fill due to public service commission processes and approvals. Gender barriers. Female health workers face cultural and safety barriers, particularly in rural or other regions. Low rural appeal. Qualified professionals. Excuse me. Sorry. Low rural appeal. Qualified professionals prefer urban postings, rural facilities face perpetual vacancies. Credential gap, mismatch between available training and the skill requirement of district health systems. Political interference, merit based selection undermined by political patronage and informal work networks. Ghost employees, staff on payroll not physically present, reduces effective workforce strength. So we have different examples for these challenges. For example, one of the challenges I recently heard was that of credential gap, that there is a mismatch between available training and the skill requirements of district health system. So there was a person who has got training in hepatic transplant, and he got training from abroad, and when he came to Pakistan for a specific program in Atashikir hospital in a big city, and when that program didn't work for after a couple of years, he was transferred to a very small rural area in the periphery. That person was a high level consultant of hepatic transplant, and his services were being wasted working at a very small center where there was no availability of even gastroenterology services, let alone hepatic transplant. So there should be a balance between the credentials or the activities or qualifications of a doctor or a healthcare professional, and where that person is going to be placed. So there is should be a needs assessment and a balance between placement and the qualifications. Now we come to the next section, which is training and development, building capacity, competence, and a learning culture. Training needs assessment, a systematic process to identify the gaps between current and required competencies. First, we have organizational level, which includes strategic gaps, departmental needs, system wide competency deficits. Then we have job or role level, task analysis, knowledge, skills, attitude required for per cadre. And finally, we have individual level performance reviews, self assessment, 360-degree feedback, or supervisor's rating. There are different tools for training needs assessment like surveys, focus groups, frameworks, job analysis, review of incident reports, and so on. Types of training in health sector. So we have induction training, orientation for new staff on systems, policies, culture, and clinical protocols. Then in-service training, continuous training while working through CMEs, short courses, skills lab, and workshops. Then we have mentorship and coaching, one-on-one structured guidance from experienced supervisors or peers. E-learning and distance, like online platform, WHO Academy, Coursera for Health, national LMS portals. Then we have leadership development, management training for mid-level and senior health manager, MPH, executive courses, and so on. These courses are done, leadership courses like MPH were done extensively at Institute of Public Health. Similarly, leadership development courses like particularly for Punjab Healthcare Commission and also IDSR training courses. They are being done at Institute of Public Health, and these are an integral part of the trainings in the healthcare system in Punjab. Then we have shifting training, which trains lower cadre lady health workers or community health workers to perform expanded roles safely to address workforce gap. Um, of course, task shifting training has its own benefits and negative effects. It helps to cover the gaps when there are less number of human resources available, but at the same time, it puts extra pressure and sometimes immense pressure on those lady health workers or lady health visitors, and they are required to do much more than what their job description is there for. And so the quality of their work and the reach their work can do is very much affected. So it task shifting has its pros and cons both. Then we have continuing professional development, CPD. CPD is the ongoing process by which health professionals maintain, improve, and broaden their competencies throughout their careers. For that, we have Pakistan Medical Commission or Pakistan Medical and Dental Commission, which gives 25 CME credits per year, which are required for license renewal for doctors. Then we have Pakistan Nursing Council, CPD framework for nurses is under development, registration renewal after every 5 years. Then we have CPSP, College of Physicians and Surgeons, mandatory structured CPD for fellows, logbook, and supervisors sign offs. And finally, we have WHO recommendation, minimum 50 hour per year of CPD for all health professionals. Now we came to the next section of performance management. For that, we have a performance management cycle, which is a continuous process, not just an annual event. It starts with goal setting, set smart objectives aligned with facility, district health targets. Then we have monitoring and coaching, regular check ins, supportive supervisions, real time feedback. Then appraisal and review, structured annual, semi-annual performance reviews against objectives. And finally, we have developmental planning, identify learning needs, create individual development plans. Performance appraisal tool and methods. We have for that annual confidential report, which is also known as ACR, traditional civil service tool used in Pakistan for government health employees, written by supervisor or the most senior above, limited feedback to the employee. Large one way only, limited developmental value in current scenario. Then we have 360-degree feedback, which is multi-source feedback from supervisors, peers, subordinates, and patients or clients, more comprehensive and balanced, which is it is best for leadership development roles. Then we have balance scorecard, measuring performance across four perspectives: financial, customer, internal process, learning and growth, which is excellent for health facility management. And finally, we have key performance indicator or KPIs, which are specific measurable metrics tied to job roles. For example, OPD consultations, vaccination coverage, antenatal care visits. These are more objective and useful for clinical staff. Managing underperformance, a structured approach. Underperformance should be addressed early, fairly, and with a focus on improvement, not punishment. So, step one is to identify and document. Record specific performance concern with evidence and date. Avoid vague language. Step two is private conversation. Meet the employee privately. Ask questions first. Understand root causes like workload, personal issues, skills. Step three is performance improvement plan. Set clear targets, timeline, and support measures. Both parties sign on it. For step four, we have monitor and support, regular check ins, coaching, remove barriers, document progress. For step five, we have formal action if needed. If no improvement, follow disciplinary procedures per HR policy and labor laws. Now we come to compensation and retention. Components of a total compensation package. It has financial components and non-financial. For financial, we have basic salary, BPS salary scale for government, special allowances, rural hazard or on-call, overtime and professional fees, pension and provident fund, performance-linked pay emerging in Pakistan. Then we have non-financial components, which include government housing or accommodation allowance, professional development opportunities, recognition and awards programs, safe and supportive work environment, work-life balance, and flexible scheduling. Motivating health workers theoretical frameworks. For that, we have Maslow's hierarchy, application in health sectors, which ensure basic needs like pay, safety before expecting higher motivation. Many healthcare workers lack basic security. Then we have Herzberg's two-factor, and its application in health sector is that hygiene factor like salary and supervision prevent dissatisfaction. Motivators recognition, growth, drive performance. Then we have self-determination theory, which is health workers need autonomy, competence, and relatedness. Over supervisions undermine intrinsic motivation. And then we have expectancy theory, which means that effort leads to performance, lead to reward. Linkage must be clear and trusted. Broken promises demotivate surely. Health workforce retention strategies, evidence based intervention to retain health workers, especially in remote and underserved areas. We have financial strategies like rural remote allowances, 25 to 50% premium, student loan forgiveness scheme, or housing subsidies. Then we have educational strategies, sponsored postgraduate training, priority for specialist training slot, CME funding, and study leave. Then we have professional strategies, clear career progression pathways, scope for clinical specialization, involvement in research. Then we have social strategies like community integration support, school access for dependents, spouse employment assistance. So these are some global frameworks for health personal management. Let's see. So there are many frameworks, but we will be focusing on few right now. So we have HRH Action Framework, Workforce 2030 Strategy, Global Code of Practice, Health System Building Block, Working Together for Health, which is a WHO World Health Report, Human-Centered HWF Framework, which was published in BMJ Global Health. Then we have HRH Optimization Framework by WHO and HRH Effort Index by Capacity Plus and USAID. So we come to the first and the most important framework, which is also known as HRH framework. It is the most widely used operational framework for health workforce management globally, developed through the Global Health Workforce Alliance, designed specifically for low and middle income countries. Four action cycles, which include situational analysis, planning, implementation, monitoring, and evaluation. And action fields are policy, finance, education, leadership, partnership, and HRM systems. Let's see, this is the diagrammatic representation of this HRH framework. As you can see in the upper side, we have situational analysis, planning, monitoring, and evaluation. And in the middle of that cycle, we have policy, finance, education, partnership, leadership, and which leads to implementation, which leads to improved health workforce and health services like equity, effectiveness, efficiency, quality. And the final outcome is better health outcome for everybody. Now we come to WHO Global Strategy, which is Workforce 2030. Overarching global policy framework to achieve universal health coverage and SDGs through health workforce strengthening. Objective 1 is optimize performance. Objective 2 is align investment. Objective 3 is build institutional capacity. And Objective 4 is strengthen HRH data. Now we come to WHO Global Code of Practice on International Recruitment. 193 member states adopted this code, voluntary but universally endorsed. Its key principles include ethical recruitment, protect source countries, train and retain domestically, data and transparency, rights of health workers. Then we have WHO health building blocks. We have been gone through them a couple of times in the past month. It is the health workforce is one of the essential six building blocks of any well-functioning health system. So there are different components, six main building blocks, and health workforce is one of the most important and critical building block. So the goal is to improve health outcomes, responsiveness, financial risk protection, and improved efficiency. Then we have Working Together for Health. It was a WHO 2006 World Health Report first quantified the global workforce crisis and placed HRH at the center of health system strengthening. Key definitions include all people engaged in actions whose primary intent is to enhance positive health outcomes. It was identified that 4.3 million worker global shortfall was present, and now it has been revised to 18 million by 2030, and it has different components. So these were the some important and essential framework present, and I have tried to explain them with their main component and their main principles. And now we come to the key message of this presentation, which is that no single framework is sufficient. Effective health human resource management requires combining them and using them in your own system and to the demand of that particular system and in that particular context. So this is the central message of today's lecture. Now we come to human resource management in Pakistan health system. What are the challenges, reforms, and what is the way forward? So in Pakistan, as this has also been explained in different contexts in the past month, but let's revise it that at the federal level we have Ministry of National Health Services and Pakistan Medical Commission and Drug Regulatory Authority. These are the organizations and health services which are working at federal level. Then at provincial level we have health departments, health services academies, and provincial health authorities. At district level we have district health officers, district health authorities, and ETO health. And facility level, we have THQ or DHQ, hospital management, BHU in charges, and medical superintendents. Some key human resource management challenges in Pakistan health system include severe skill mismatch, as I gave you an example previously. Urban and rural imbalance. 70% of the doctors serve urban areas, rural areas with 63% of the population are grossly underserved. Then we have the major issue of brain drain. Thousands of doctors emigrate annually to UK, Gulf states, USA. Public sector loses trained talent. Gender equity gaps. Female health workers face safety, mobility, and cultural barriers, limiting service delivery in conservative areas. Weak HR information systems, incomplete workforce data, no integrated HRIS, decisions are made without evidence. Training service disconnect, medical education poorly aligned with district level health needs, public health capacity is particularly weak. HRM reforms and policy initiatives in Pakistan. Recent and ongoing government initiative to strengthen health human resources includes National Health Vision 2025, which targets increasing physician density to 1.2 per thousand and nurse density to 1 per thousand, includes HR development. Currently, the nursing density is even less than the doctor density, which is about 0 0.4 is the nurse to per thousand population. PMC Act of 2020. Then we have Lady Health Worker Program, Sehat Sahulat Program, Natural HRIS Development, and Provincial HSAs. For way forward for Pakistan is to plan evidence-based HR planning, align education with the needs by training, retain uh, and particularly develop rural retention packages, and revamp performance systems and decentralize HR authority. So these are some of the key takeaways that HRM is strategic. It is just not administrative. It drives patient outcomes and system performance. Health workforce planning must be evidence-based. Recruitment and selection should be merit-based, transparent. Training should be continuous, competency-based, and aligned to the real needs of the system. Retention requires a mix of financial and non-financial incentives. Pakistan health HR challenges are significant but solvable through political will, investment, and reforms. Now we come to multiple choice question part of the presentation, which features best distinguishing modern human resource management from traditional personnel management. Focus on payroll administration, emphasis on strategic workforce development, limiting employee participation in decisions, reliance on disciplinary supervision, or short-term administrative planning.
B.
Yes, it is B is the right answer. Our provincial health departments want to estimate the number of physicians required to address future disease burden and service coverage targets for universal health coverage. Which workforce planning method is most appropriate? Population ratio method, workforce utilization analysis, health need-based planning, random workforce allocation, or vacancy replacement method?
C.
C.
It is C, yes, health need-based planning. A district hospital is experiencing repeated staff shortages despite having sanctioned posts. The HR manager analyzes vacancies, absenteeism, and skill mix of current staff to improve deployment efficiency. Which planning approach is being used? Workforce utilization method, health needs assessment, population ratio method, recruitment forecasting, or training gap assessment?
A.
A.
Yes, it is A, workforce utilization method. A health facility recruits doctors from within its own workforce through promotions and departmental transfers to fill leadership roles. This recruitment approach is classified as external recruitment, contractual hiring, lateral recruitment, internal recruitment, or temporary recruitment.
D.
B.
Yes, it is internal recruitment. A systematic process used to identify the difference between existing staff competencies and required competencies for job performance is called human resource audit, workforce forecasting, training needs assessment, competency certification, or organizational evaluation.
C.
Yes, it
A.
is C, training needs assessment. A hospital collects performance feedback on departmental head from supervisor, colleagues, subordinates, and patients to evaluate leadership effectiveness. Which appraisal method is being applied? Balance scorecard, 360-degree feedback, annual confidential report, key performance indicator, or competency checklist?
B.
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 C.
Yes, it is
B.
360-degree feedback. Which performance measurement approach evaluates organization across financial, customer, internal process, and learning perspectives? Workforce utilization review, annual confidential report, behavioral observational scale, balance scorecard, or task performance audit?
E.
A.
No, it is balance scorecard because it is using that those four perspective from financial, customer, internal process, and learning. So this is balance scorecard. A public health manager identifies poor performance in vaccination coverage by a staff member. The manager documents the issue, discusses causes privately, and sets clear improvement targets with timelines. Which management tool is being used? Disciplinary inquiry, workforce redeployment, performance improvement plan, renegotiation, or competency recertification.
C.
C.
Yes, it is performance improvement plan. According to Herzberg's two-factor theory, which of the following is considered a motivator rather than a hygiene factor? Salary scale adjustment, job recognition, workplace safety, administrative supervision, or employment contract.
C.
Um, according to
B.
this, yes, according to particular this theory, job recognition is considered a motivator according to this theory. So this is the answer key. This is the YouTube channel where this video will be uploaded. And thank you very much for listening.
Thank you so much, Dr. Taimia.
Thank you.